I declare that all the work that you're seeing is my work. I do not work for Septodont, although a lot of people assume I do. It's just that I just love these materials so much. So today's lecture will have a lecture overview. I will be discussing mineral trioxide aggregate because that is where I started my career. We'll be discussing bio-brothers or bio-siblings, as has been suggested today. Then since we have brothers and siblings, we will be discussing a little bit the rest of the family. We will then need to classify because the family has grown into a very big family. And at some stage, we will discuss the aliens. So I will be showing you, I think, if you take nothing from my lecture, I will be showing you a few pictures. Gray, 50 Shades of Gray as well, but it is important to remember the images are very, very important. I mean, I think now I can be declared as the official photographer of hydraulic cements. Yes, because it is very important to understand the microstructure, understand the chemistry, and then you can start predicting material behavior, because all the materials are not the same. So this is where we started, the mineral trioxide aggregate, the ProRoot, which was the first one by Densply. And this is a very, very simple material, and you think, oh, but those are very big names. That's nothing. That is just a sack of cement. But that sack of cement happens to be composed chemically of, can you see the word repeated? Silicate, a bit of tricalcium aluminate, which is really a bit, less than 5%, and the calcium sulfate. The calcium sulfate is added at the end to make the reaction go slower. So if you have a bit of brain, you would say, well, if I want to make it go faster, I will eliminate the calcium sulfate. But it's not as easy as you think. So we started from a sack. We couldn't see it on a radiograph. So the next obvious thing to do was to add some bismuth oxide. Nobody asked what is wrong with bismuth oxide. They just added it because it happens to be very low on the periodic table. And the most important part of this story and where we started is the addition of water. So remember this slide, because any other material on the market is a modification of this slide. So if you look at the features of this material, you will see that it is hydraulic. And this word hydraulic is abused. Everybody invents something with hydraulic. So hydraulic, for anybody who knows any languages, means water. It doesn't mean hydraulic pressure. There's no hydraulic condensation. It means that we need water, strategic, to add to the material, very strategically, and the material interacts with water in the environment. So we have two factors, the addition of water to the material, and also the interaction of the material with the liquid in the surroundings. Also stress the calcium ion release. All that results in a change in biocompatibility, antimicrobial properties, calcific bridge formation, and biomineralization. But there were some main clinical concerns. This material has had a lot of clinical success, but one cannot close their eyes and say, oh, it's fine. There's no problem with this material. No, there are some problems with the material. The problem is, one, the aluminum, trace elements. And one of Amre's slides had something interesting in it. Purified Portland cement. What is purified Portland cement? That's a gimmick. You cannot purify Portland cement. Portland cement is made for industry. You cannot purify the Portland cement. It is what it is. You either accept it or discard it and go for something else. The extended setting time, which I've said why, essentially, the extended setting time is because of the calcium sulfate, manipulation and placement. It is very sandy and very annoying material to use, although some clinicians tell you, I'll use it and I'll use it all my life. The bismuth oxide, because it is of concern, because it causes tooth discoloration, and the environmental factors, but that is us, the clinicians. Somebody suggested earlier, I think it was Angelo, it is about having a clinical protocol, which to date, with all the 20 plus years of research, nobody has suggested a clinical protocol. What was key, in my opinion, with the MTA, the key problem is that people add as much water as they like. And that is wrong. As soon as you start adding the water, the material becomes soluble, and also, in the long term, the material is ruined. So essentially, who is opening sachets and adding water as much as they like zinc oxide eugenol, stop doing it. Do not open sachets, leave them open and reuse them. Gilles Richard mentioned a very, very important property. It's hygroscopic. It collects the moisture from the environment. So two very, very bad practices is opening sachets and adding as much water as you like. Bismuth oxide causes tooth discoloration. Some people will tell me, I'll use it at the back. It's fine. Doesn't matter. It matters a lot. When bismuth oxide meets sodium hypochlorite, you get a change in chemical structure. It is no longer alpha bismuth oxide. I have a nice paper, hopefully I'll publish it soon. It becomes something else. So you're putting something in a patient where the clinical environment is changing the chemical structure of your material. If you are to go to court, you lose your case because you put in an alpha bismuth oxide. After 10 days, approximately, the patient has another material in their mouth. It is discolors tooth structure, as you have seen, and it is very, very ugly. So, again, a very, very important slide. When you buy a new material, it is very, very important that you ask yourself, is it a hydraulic cement? Reply will be possibly yes. What is the vehicle? Do I mix it with water? Yes or no? Then, from the components, identify which is the cement or cements, which is the radiopacifier, and which are the additives. So, if we're discussing MTA, the MTA is added with water as a vehicle. It is a Portland cement, so it is tricalcium and dicalcium silicate. It has bismuth oxide and no additives. My 50 shades of gray, that is what Portland cement powder looks like. The darkish particles are cement, the shiny ones are bismuth oxide. What is key is, if you look at that slide, because I'll be showing you other slides, I said I'm the official photographer. If you look at that slide, can you see the porosity? Which is key, which is why the first generation material is not as good as the other materials. So you will be able to see a lot of porosity, okay? Which, obviously, if the material is porous, the material is not as strong as non-porous materials. So I've explained the MTA. Now it is very easy to explain the Bio Brothers. So, presentation, the Bio Brothers are, to me, the first generation of these material types, which is the biodentine and the BioRoot RCS. So both biodentine and BioRoot RCS are mixed with water. They are tricalcium silicates, pure tricalcium silicates. They have zirconium oxide and some additives. You see, I mean, if you subdivide that, it is very, very easy to understand why materials behave in the same way. My best image of a lifetime, very, very nice image of the official photographer. Do you see any porosity? No. What you see is a very, very ordered microstructure. Ordered microstructures usually give very, very good properties because the material is engineered in such a way where as soon as you mix it with water, the hydration reaction goes around the calcium carbonate particles and this structure falls together very neatly, giving enhanced properties. So the advantages of this material is that the main component is tricalcium silicate. There's no risk of tooth discoloration. You can use low water to cement ratios because there is the super plasticizer, and that gives, as soon as you reduce the water, you will get higher strength. It has an enhanced hydration because the particles are very, very small and predictable levels of calcium hydroxide. It affects the antimicrobial characteristics. It affects cell growth and differentiation and the hard tissue formation. You can see in this slide the short setting time, the high strength, adequate radio opacity, high calcium ion release, dentine bridge formation, and the material is clearly antimicrobial. So, a very, very important reaction to remember. The reaction needs water and the formation of calcium silicate hydrate and the calcium hydroxide. So, on this side of the slide is the famous biomineralization. Hyped up a lot, in my opinion. How do you know that when you put actually the material inside somebody's body, it's going to form those crystals? Those crystals only form in the lab, where you have things at a controlled pH, controlled volumes, controlled everything. In the human body, you can get that, but you can get that or that. That is porosity, that is non-setting. Who is in control of the environment? We are in control of the environment, which is why I stress the very, very big importance of clinical protocols. So for hydraulic cements, and you can forget the rest of the slides, the importance is the chemistry, the clinical presentation, and the environment. The environment is tissue fluids, the environment is dentin, irrigating solutions, and other materials that we will put over the hydraulic cements. From the clinical perspective, I think the setting time is very, very important. The solubility is also very important, and also the long-term stability. This is a lot about bioactivity. I can stand here for days discussing bioactivity, but like I said, all that reaction happens only in the lab. These beautiful crystals that we've seen, the formation of the calcium phosphate on top of the material surface, again, happens only in the lab. This is how we question the bioactivity. Can it be tested in vitro? Not really, unless you have a brilliant setup. But I had the opportunity to collect some materials which came from patients. So we have a failed case there, we had an animal study there, and this very elegant article by a colleague of mine, the group at KU11, where when we collected material that was actually inside the patient, all we deposited was calcium carbonate. But obviously, as dentists, we like thinking of bioactivity, phosphates. Calcium carbonate is not sexy enough for us. So we ignore it. Now it never happened. Does the material actually set? Because I hear everybody asking me about putties, materials that do not need mixing of water, and that was a question I asked myself. I had approached the Madabu whether the biodentin with a composite over it actually sets, and it does. As you can see from there, there are reaction rims of the material when it is used in vivo. So it is very important that we are able to translate the in vitro to the in vivo characteristics. It is extremely antimicrobial, but it is very, very important, especially when in contact with blood, because these materials are used in contact with blood. It is extremely important to realize that blood, irrigating solutions, and anything else we add will reduce the antimicrobial characteristics. So it is important that we use materials that set and actually release the calcium hydroxide. Again, you see the effect of the final irrigating solution. Materials that contain phosphates are not suitable because obviously they will be reducing the pH. I heard people using the chlorhexidine. It's a big no. Chlorhexidine, as you can see from the slide, I have to rush on, but I am more than happy to provide the slides. Chlorhexidine interacts with the material properties. So it's very, very important. Do not use chlorhexidine prior to placing these materials. So this is a concept that I have introduced, and I would like people to think a little bit about it. It is very important that you match your irrigation with the material that you're going to use. So if you're using, let's say, something like AH+, AH+ does not have antimicrobial properties. So the last irrigating solution needs to be sodium hypochlorite. If you're using materials that are antimicrobial, always end with something which is moisture, things like sterile water. Okay? I still do not have much evidence about this, but try to help the material behave in a good way clinically. Okay? And if you look at the environment, it is very, very important because a lot of publications are showing that these materials are extremely soluble. You have to start questioning the methods which we're testing them. The ISO standards for sealers are not suitable, and I make a very big statement here, are not suitable for these material types. And we show it very clearly here. When we test solubility, we weigh things, and we weigh things in water. The human body is not water. The human body is salts. So essentially, if you're weighing and you have a salt, anything which is deposited on the surface is weighed. If you put it in water, there are no salts on top, and obviously it weighs less. Okay, so very, very important, we don't go overboard with the question of solubility. What about the rest of the family? So these two materials have done very well, but Septodont decided to introduce more members to the family. So the members to the family, we have now the Biodentine XP, where we get two types. We get the 200 and 500, because a lot of clinicians were complaining because they had too much, because before it was 700 micrograms, and there was a lot of waste. We have a new mixer there, and that happened so the clinician does not abuse the material, opening the capsule, and does whatever clinicians like doing it their way, and how it works in my hands. We have the other member of the family, and the other member of the family now is the BioRoot flow, and you see the change with the BioRoot flow, which is in the vehicle. Instead of the water, now we have a material which has an alternative vehicle, and the alternative vehicle enables the material to be placed in a single syringe. Very, very good properties. In fact, if you like doing warm vertical compaction, I would suggest you go to BioRoot flow, although the company does not suggest the BioRoot flow for warm vertical compaction. I'll show you some nice images. Since it does not have water, the properties are not affected by the heat. So if you look at single cone obturation, and this is again, as the official photographer, one of my best slides. So if you look there, can you see those crystals in the gap? That is evidence of self-healing. You get a crack, the crystals form, they close the gap. You see, I'm a very good photographer, and you can see here the gatta perca, the tooth, the material. You see how compact the material is. That is the one vertical. Do you see any gaps? Do you see any spaces? I'm a very good dentist, that I am able to see there how my materials are adapting. And you can see, even with one vertical compaction, these materials behave extremely well. What I need to stress is when the material is not added to water, you have to get the water from the environment. How do you ensure that you get the water from the environment? The only way to ensure how you get the water from the environment is by using continuous chelation. If you chelate, you open the dentinal tubules, and for sure you will get pushback of fluid inside the canal in the long term. If you leave the smear plugs, obviously, you have blocked the system. So if you're using these material types, I suggest chelation. So I'll go into the classification. I will introduce the aliens, and after introducing the aliens, I will invite my colleague back to the stage. So I have shown you the silicates. I have shown you what is available on the market with regards to silicates. So I've introduced this classification because people keep on calling these materials bioceramic. And to me, that is a very, very bad term to use. So we should call them hydraulic cement. So we start with a hydraulic cement. The hydraulic cement can be a silicate. The silicate can be a calcium silicate. So biodentine and BioRoot will fall there because they're calcium silicates. If it is added with water, it is there. Bioroot flow will fall there, but all under the calcium silicate. Okay? There are strontium silicates nowadays, but the danger is when you go to hydraulic cements that are aluminates, which people call bioceramics. Those are the various uses where you can use these materials. So, let's discuss the aliens. Who are the aliens? The aliens are the ones that are imposters. They are called bioceramics, but actually, they do not do the job. So, I have a lot of friends in Italy, so I was there trying to speak in Italian. I was approached by Filippo Cardinali, and he told me, Josette, I have a very big problem with this bioceramic business. He told me, how much do you need of the calcium silicate for the calcium silicate to be effective? I said, really and truly, I do not know. I said, let's look a little bit at what we have on the market to see if these materials that are badged bioceramic, whether they're all the same. So, we found the first problem, the duo syringe. As soon, currently, as you see a duo syringe, automatically it is a resin, because these materials cannot go in duo syringes. Okay, so presentation needs to be powder liquid or a single syringe. But then you can see the variation with the composition. Cement, the tricalcium silicate, varied from 5 to 35%. Do you think that it is comparable to have a material which is 5% cement only to a material which is 35%? Tricalcium aluminate, 50%. That's crazy. It is not a silicate. You cannot claim the same properties. Radiopacifiers, up to 70%. You do see it on the radiograph if you have 70%. The additives varied a lot. The vehicle varied a lot. And some materials have salicylate resin. With this paper, which was published at the beginning of this year, we compared 3 single syringe hydraulic cements. They do not have the same properties at all. And in fact, one of them was so soluble, we couldn't even keep it together to test. And we're putting, these materials are on the market. These materials are not quality controlled, but they are present on the market. We're putting them on the patients because they are class 2B devices. They do not need a certain quality control. So a lot of companies have become packaging companies. So it is very, very important. It has to be a silicate reaction. If it is a Portland cement, it will have those 3. If it is a pure tricalcium silicate, it will have the first reaction only. Only these materials produce the calcium hydroxide. If it is an aluminate, it produces aluminum hydroxide. Has anybody ever tested aluminum hydroxide to see if it works, if the cells grow, if it is antimicrobial? I haven't. Anybody? No hands up? But most of the materials that are badged as bioceramic are those. And I've proved it many, many years ago. That is part of my PhD, where actually they do not work. They're not biocompatible, and most of the calcium hydroxide is not even present there. To conclude, because I have a red flashing at me there, I will conclude with the importance of knowing the material chemistry. I know it's a bit of heavy chemistry, and beware of the aliens. Control your clinical environment, because the environment is something that only we can control, and match the materials you use with the clinical environment. Thank you very much for your attention.
Thank you very much for accepting the invitation to be here, and I have an honor to share a stage with Dr. Camilleri. So I wanted to share you my experience using these hydraulic sealers. And when we think in root treatments, we have 3 parts: cleaning, shaping, and canal obturation. And in the part of the canal obturation, we always think about guttapercha, but we need sealers to do our obturations. What happens with the traditional sealers? They have several drawbacks that we have to take in considerations. They have shrinkage and poor adhesion to the dentin and guttapercha, so they can lead to micro leakage. The biocompatibility is not adequate. They do not set in moisture. They have lack of bioactivity, poor antimicrobial activity, and degradation over time. So, with these hydraulic sealers, we try to solve these problems using a technique that is called single cone technique or even hydraulic filling technique. The hydraulic filling technique is called because we do not obturate anymore. With these materials, we now fill the canal, so it's totally different. We must change concepts that we have learned, and we must rely on the sealer. So it's very important, the sealer, in this kind of filling. And obviously, these materials are intended to use in a cold technique. But we use guttapercha because two reasons. The guttapercha acts as a piston that pushes the sealer apically and laterally and fill all the clean canal space. And if we want to retrieve these cases, it's very important to have a path of guttapercha to retrieve it, to make it easier. If we compare the traditional single cone from the 50s and the 60s, that we use traditional sealers, when the sealer sets, we have shrinkage. So we have a lot of voids and gaps. With these new sealers, it's totally different because this sealer has expansion. So the important here, although there is the same technique, the important here is the single cone technique, is the sealer. We have this article from Martin Troop and Gilberto de Bellian that they test a lot of sealers, and the unit that have expansion is the hydraulic sealers. So this is the reason we use these sealers now with single cone technique. We have to prepare and shape our canals with a continuous coronal apical taper preparation, and we have to do a perfect cone fit. I normally use a 4 taper cone, and in this case, with these materials, we are capable to promote periapical healing, bone regeneration, and greater sealing through the mineralization and apatite deposition of the dentin walls. This is called biological sealing. This is new. With this sealer, we have this biological seal that is different from the traditional hermetic seal. If we classify these materials, depending on the dispensing method, we have two materials. One component, that is the premix, the cold premix one, and the two components material, this is no premix. In the two components, we have a powder and a liquid. And we have a lot of experience with this bioroot that was launched in 2015. So we have years of using it. And if we see the composition, it's a pure tricalcium silicate with the active biosilicate technology of Septodon. We have the radiopacifier and the Poveran K19 to addition to GP. There is no aluminum, no resin. And in the liquid part, we have water. This is the vehicle. A setting accelerator that is calcium chloride, and a water reducing agent that is a hydrosoluble polymer. These are the properties that we have. It is highly biocompatible and low cytotoxicity. There is no toxin. It has no dimension changes or expansion. It's hydrophilic. It's because these sealers love moisture. They need moisture to set. They are bioactive because they produce something similar that hydrous apatite. It depends if in vitro or in vivo. It produces light inflammatory response in periapical tissues. It has excellent sealing. It bonds to the dentin and to gutta-perca. It's antibacterial because of the production of calcium dioxide. It's easy to use and manipulate, and the radiopacity is adequate. We mix 1 scoop of the powder, 5 drops of the liquid. We mix 1 minute, and we obtain a creamy consistency that we have to put inside the canal. I present some of the people that is in our group, that we study biological properties, most centered in biocompatibility and bioactivity, when we put together the sealers and the stem cells, the human stem cells. And I would like to present this research from 2017, where we studied biocompatibility of 3 new calcium silicate endodontic sealers with the human PDL stem cells. You can see here that the BioRoot was the best in cellular proliferation, the cellular viability, maintains the phenotype of the stem cells, and the best in cellular migration. So it's a good product. It's a very good product. So the conclusion is that the BioRoot root canal sealer was the best material in terms of biocompatibility. I would like to present this article that was published 2 months ago. It was a randomized clinical trial with a 4 years clinical and radiograph follow-up, comparing BioRoot canal sealer with a single cone technique and the pulp canal sealer extended working time with a continuous wait technique. And they conclude that the success rate is similar, and the use of this BioRoot with a single cone technique appear to be at least as reliable as the traditional continuous wait technique. So it works. The technique is easy. We moist the master cone with the sealer. We insert the master cone in the canal several times with a pumping motion. Then I cut 1 millimeter of the apical part of the master cone. I moist this apical part in the sealer and introduce again this master cone slowly until the working length. Then I take an X-ray, and if it's okay, I cut the gutta-perca at the orifice level and plug the gutta-perca. This is the pumping motion. You can see here how the sealer is going to the apical part and the lateral canals, and then cutting 1 millimeter, moist the gutta-perca point and go through the canal until the working length. Let me show this case. This is a symptomatic parodontitis, apical parodontitis of 44 tooth with an apical lesion. So we retreat, we do our working length, we shape, we clean. This is the cone feed radiograph. And this is the way we put the sealer inside. You must go several times with a pumping motion. Then when we see that the canal is all the walls are with sealer, we can do the cutting of 1 millimeter of the master cone and going with the master cone to the working length. There are a lot of ways to do this. There are a lot of techniques. This is how I use it. Now we take an X-ray, and if we like the X-ray, we cut the gutta-perca at the orifice level and plug it. So this is the pre-op, this is the post-op, and the last recall is an 8-year recall where the tooth is in function, it's asymptomatic patient, and the bone is still healed. This is an CBCT that was taken for an implant procedure, and we can see here how the tooth is going. So it's very nice. This is a retreatment of a 46 that with two sinus tracts. We have here one sinus tract and another here. With a big lesion, it's a very symptomatic. Look this CBCT. I only have this axial view because it was sent to me from another country. And we do the walking length. We clean the best we can. Then we do the technique we've seen before. And this is the post-op. You see, it seems that it's short. But as I've said, I normally cut 1 millimeter of the cones. And this is an 8 years recall. So the tooth is in function, and the patient is asymptomatic. And look the healing of the bone, so it's totally healed. And on the other hand, we have the one component material. The one component material, we have some advantages because it's a per-mix sealer. We have time waste, it's easy to use, and the mixing is perfect, and the handling is very easy. And we have in the market a new BioRoot flow. Last year was launched in Europe, and 2 years ago in the United States. This is very similar to the BioRoot. It's also calcium silicate with the technology patented by Septodon. And we move to the composition is very similar. We have the pure calcium silicate. We have the zirconium oxide, the povidone. The setting accelerator is different, and the vehicle is different because it's a per-mix one. Both BioFlow and BioRoot canal sealer meet the specifications of one ISO that is old for these materials. But if we compare, the working time and the setting time is longer from BioRoot flow. The flow and the radiopacity is similar, and the film thickness and the solubility is smaller. So it seems that it's a little bit better than the classical BioRoot. We have published last year 2 articles studying the biological properties of this material, and the conclusion of both is that BioRoot flow can potentially enhance cell differentiation by promoting the expression of essential genes related to bone and cement formation. And additionally, BioRoot flow displays anti-inflammatory effects. We don't have evidence of this material because it's very new, but I think it's a very good product. The technique, we have a lot of ways to do it, but it could be an easy and direct technique because we take off the cap and we adjust a tip. We insert the tip into the coronal third. This is important. For me, it's important to put the sealer only in the coronal third, a small amount of sealer. Then we can spread the sealer with a lentil or a file to the apical part. This is optional, and it's optional to take an X-ray to see if we have sealer all along the canal. More of times, I cut 1 milliliter of the apical part of the master cone. I immerse this master cone in the sealer and go into the canal slowly. Then I take an X-ray, and if everything is okay, I cut the gutta perca at the orifice level. So the important thing is not to push the tip of the couch close to the apex, because we can have extrusion of the material. Then we cut a millimeter, we moist it in the tip, the rest of the sealer that is in the tip. And this is a picture that we can see the cone feed. Only in the coronal third, we deliver the sealer. We can move it to the apical part. Then we cut a millimeter, go with the master cone to the working length, X-ray, everything is okay. We cut it at the orifice level. So this technique The setting reaction is different from the bioroot because this is a premixed one. So the setting reaction occurs thanks to the humidity of the dentinal tubules. Is different from the bioroot classic RCEs that the setting reaction begins when we mix the powder and the liquid. It's totally different. But as I said before, the correct cone selection and proper canal preparation help to push the material to the apical part. And it's ideally that the last millimeter of the canal should be only filled with sealer. I would like to show you this extracted tooth obturated. So when we cut the apical part, there's only sealer. Then we will go to the coronal part. We have the cone, and all is filled, all the space is filled with the sealer. Now I'm going to show you some cases of this new material. I only have 3 months recall because it's very new. This is a 41 with a symptomatic periodontitis. We clean and shape. Here is the cone feed. We have 2 canals. We put the sealer with a tip. When we put the tip in the coronal third, we press the sharings, but we have to move to the coronal part. At the same time, we are pressing the sharings. Because if not, the sealer is going to the apical part immediately. Then we go with the cones, with the 2 canals. Here we don't have to do the pumping motion. We have to go directly to the apical, to the working length. Because if we do the pumping motion, we can obtain bubbles or bubble lock. So it's easier to go directly to the working length. Then we take an X-ray, and if it's okay, we cut at the orifice level and plug the gutta-perk. So this is the post-op, and here we have the 3 months, and I know that is a short recall, but it seems that it's smaller, the lesion. At least I think so. And the second case is this 36 with a necrotic 36. We have 2 lesions in the mesial root and in the distal root. The lesion of the distal root is laterally, so we clean and shape. It's very difficult to clean and to shape the distal root. Then we put the sealer with the syringe. This is the mesials and the distal one. Always the same. We go with the cones. Then with the distal canal. This is the post-op. This was very difficult to clean and to shape. And this is the 3 months. Now, here we can see that the lesions are going well. And what about the worn techniques? The material is intended to do with cold techniques are worn techniques. It's different than the bioroot root canal sealer. There is an article published last year comparing 2 sealers, different sealers under thermal conditions, and they conclude that the bioroot flow have stable chemical properties, which makes them suitable for clinical application under thermal conditions. So bioroot flow you can use with worn techniques, but bioroot root canal sealer we have to be cautious in its application in a worn obturation technique. So if you want to use the worn technique, you must use bioroot flow. Don't use the bioroot root canal sealer. Let me show you this case where the MB1 is going to be done with the worn technique and MD2 with a cold technique. So here we have the MV1 and the MV2. At this point, it's called technique. We put the sealer with the sharings. We introduce the master cones. Then we cut at the orifice level in the MV2. And I go through the middle of the canal in the MV1. Then after cutting the guttapercha, we must plug the guttapercha. We plug the MV1 and MV2. And the difference is we have to down the backfilling in the MV2, MV1 that we have done the worm technique. So we go with the extruder of the guttapercha. And that's it. So thank you very much for your attention. And this is